Hey everybody, welcome back to the daily ECG. My name is Reed. Before we start, go ahead and download the PDF for today's ECG down in the description below, and like and subscribe if you enjoy these videos. Let's jump into it. So first thing I like to do when we start ECGs is just look at the forest, and the trees of the forest are QRSs. I'm going to pick this V1 lead rhythm strip here, and I see I've got this narrow complex QRS that seems to be in a kind of an irregular type pattern. There's like, maybe shorter, longer, shorter, middle, kind of a little bit of irregular. It starts to regularize here as the ECG marches on. I do notice though that there are P waves in front of my QRSs as I'm just taking a look at this, and it doesn't appear to be any P waves that don't have a QRS with them. So lots of good P's here. And so let's take a look and just go down our algorithm. So let's evaluate for what the H tree is doing. We said there are P waves before our QRSs. Our P waves, if we look, we would say maybe isoelectric in lead 1. It's hard to say, but they are upright in lead 2. They're upright in lead 3, and they're upright in AVF. So I'm going to say that they're still likely going down this way. I would say my P wave axis is more kind of north-south, and so I would still call this a sinus P wave. Let's measure our intervals. So our PR interval, which is going to tell me a little bit more about my AV node. If I look here in V1, my QRS starts here, my P wave is here, and that PR interval is less than 200 milliseconds, which is normal. That's good. My PR interval stays the same. If I look throughout various beats, my PR interval appears to stay the same. And there are no dropped P waves that do not have a QRS. So it tells me that there is not a higher grade block here. So that is good. So we've got our atrial activity. We've looked at our PR intervals. Let's take a look at our QRS duration. I've said it was narrow. We can measure it out. I'll come down here. See, it's here. This QRS is less than 120 milliseconds, and so that's normal. My QRS axis, it is up in lead 1. Seems to be maybe isoelectric in AVF. Maybe I would say it's up in AVF, and so my QRS axis is normal, and see it's positive in lead 2 as well. This is a normal QRS axis. I look through my precordium. I see good R wave transition as we go from smaller to larger R waves as we move through the precordium. My QT interval, I'll pick this kind of R to R here, measure it out halfway. My T wave should end, which it does, before it gets to the midway point of the R to R. So far, things are looking okay. My rate, we'll kind of jump back to the rate here since we're kind of on this QRS. Rate seems to be anywhere from, 300, 150, 100, maybe 95 beats per minute. You can say plus or minus 10, right? There's some shorter ones here. There's some longer ones here. That's okay, right? Generally, we'll say it's around 95 to 100. And so the last thing we're going to do is we're going to look for pathological Q waves and ST and T waves, and this is really where this rhythm starts to pop out to me. I scan through my anatomical leads, and so we might start with, everybody has a different approach, but for me, I'll start with my lateral leads 1 and AVL first, and what I see is I do see a little bit of ST elevation here. My ST segment is there, my baseline is there, so I see some ST segment elevation in lead 1. In AVL, I also see ST segment elevation in AVL. You can see it especially here. And when you compare it to the amplitude of this QRS, that is a substantial increase in size of our T wave. We call these, let me write that again, we can call these more hyperacute T waves. And a hyperacute T wave is essentially when, we'll put this over here in our important takeaways, hyperacute T's, a normal T after a QRS is this nice, and it's in proportion to the QRS. But a hyperacute one, if I have the same exact QRS, is essentially going to increase its area under the curve. And so notice how the area under the curve of this T wave compared to this T wave is much different. And really it's because of that ST segment creates hyperacuity. And so you can see that happens here. We have an increased area under the curve of this ST and T wave, in the lateral leads. And so now I look through maybe my inferior leads 2, 3, and AVF, my inferior leads, and what I notice is that I have ST depression. And so that's ST depression there. I look at my baseline, and then my ST depression, baseline depression, baseline depression. So far, I've got in my lateral leads elevation, and I've got reciprocal changes, reciprocal depression in my inferior leads. We'll call that reciprocal, I cannot spell, reciprocal depression in my inferior leads. I scan through the precordium now. Look at my septal leads, V1, I don't see much, but V2, we've got this elevation here. V3, we've got these elevations with hyperacute T waves compared to the QRS. In V4, you've got this significant elevation as well. V5, you have a little bit of residual, but V6 seems to go back to baseline. So we get the most elevation that we see in these V2, V3, V4. We would call this anterior ST elevation. And because we have some high lateral involvement with lead 1 and AVL, we would say, I would say, with high lateral involvement. And so when I put this all together, I see ST elevations, like we said, we got anterior and high lateral ST elevations. But what we also have is this reciprocal ST depression in our inferior leads, which when you put this together with the anterior elevation, that is really concerning for ST elevation myocardial infarction. And so given the correct clinical setting, which is likely the case with this patient, they're going to need treatment to essentially recanalize whatever artery, which is likely the LAD, to restore blood flow. So hope this helps, and if you have any questions or concerns, throw them in the comments, subscribe to the channel, and we'll see you tomorrow. Have a great day.